السلام عليكم. التحية الخالصة لكل الحاضرين، وخاصة لو كان تسمح الأستاذ باسل كلمة ظريفة قبل الدعوة إلى الأستاذ للمحاضرة. باسمي الخاص باسم الجمعية التونسية لأمراض المفاصل والعظام أحيي وأشكر الدعوة التي تقدمت إلينا بها الأطباء والجمعية الأردنية للحضور إلى مؤتمركم هذا. مؤتمر ونحن يعني اونوري avec tous les honneurs حاضرين أنا كرئيس جمعية الروماتيزم التونسية اللي هي لليتار، سي التونيزيان ليج against روماتيزم. نعرفك بس ما تحبش كل الجاي، نفكر فيها نغيرها إن شاء الله. معايا زاد أستاذ إلياس بوعجينة والرئيس القادم إن شاء الله للجمعية. أشكركم على هذا المستوى العالي العلمي والتنظيم والحفاوة الذي لقيناه. شكرا. And now, excuse me, Professor,
Am I in the right place?
I invite you to present your conference update on biologics in rheumatic disease.
Okay.
Thank you.
Thank you. I'm very grateful for the Jordanian Society for asking me here, and I'm even more grateful for the delicious food. I ate so much of that delicious meat at lunchtime that I heard the last talk, and I think I'm at high risk of rheumatoid. I'm going to update you on biologics and basically more about how to manage difficult disease, difficult rheumatoid and difficult spondyloarthropathy. For the average case of rheumatoid in the UK and in Europe, when a rheumatologist diagnoses it, we send the patients to our nurse specialists and they follow a protocol, and it's usually easy to manage after that. But there are some difficult cases. So I'm going to focus on biologics, but not exclusively. I'm going to talk about the differences between rheumatoid and seronegative disease, talk a bit about the treatment landscape and some difficult cases. So when we, as rheumatologists, talk, we're always talking about autoimmunity, but to me, pure autoimmunity is things that go wrong in your primary and secondary lymphoid organs, as shown here, and that leads to an attack in normal tissue. And the hallmark of true autoimmunity is that it crosses the placenta. And we now realize that inflammation against self doesn't have to be autoimmune, but it may also start in the target tissues, such as the epiphysis or skin or gut barrier. And this is so-called innate immune-driven or autoinflammatory. And that led myself and Michael McDermott to devise this classification scheme where all inflammation against self may be autoimmune at one boundary with B and T cell driven, or maybe innate immune at the other boundary. And around the time we developed this, there was lots of evidence for cytokine therapies being effective for diseases that had a strong innate immune contribution. So when you're talking about rheumatoid and you say it's autoimmune, you have to think that maybe within rheumatoid there's lots of disease heterogeneity, and some of it might be innate immune driven or autoinflammatory. So this is a scenario where there's genetic abnormalities in proteins that influence neutrophil or macrophage or other innate cell functions, or the tissue barriers may be at fault. Now, when you look at the therapies of rheumatoid arthritis, we have the anti-TNFs, which work near the innate immune end. So the reality is rheumatoid arthritis is not a classical autoimmune disease. Rather, it's a disease which has a strong and adaptive component, but the effector phase of the disease with immune complex uptake leads to lots of pro-inflammatory cytokines, including TNF. Sorry, my slide's on a timer, I didn't realize it. And we can see that the treatment of rheumatoid target the T cells, target the B cells, target the downstream cytokines, and this is how the disease is treated at the population level. But when you use that model and you go to the clinics, I'm going to show you some data that a lot of rheumatoid is more innate immune driven, so it's what we term autoinflammatory. It gets the label as palindromic rheumatoid arthritis occasionally. There's these fluctuating attacks, joint erythema, lack of autoantibodies, a tendency towards high CRP. So this rheumatoid sits closer to an innate boundary. And I'm just going to go through this now and give you some examples. So whilst most rheumatoid is part of the herd, there are some difficult cases. So this is a classic rheumatoid arthritis. Autoantibodies predate clinical disease by up to a decade. B and T cell dysregulation, immune complexes, macrophage activation, and the disease phenotype emerges. And critical to this is citrullation of proteins. And once the proteins are citrullinated in the joint environment by not well-defined mechanism, disease localizes there. And this is the disease that typically starts slowly in the MCPs or small joints in the feet. And when the antibodies are positive, we go down the pathway, usually starting with methotrexate. So here's a case that had a rheumatoid diagnosed for several years. She presented acutely though, and she had intermittent joint swelling. Her synovial fluid analysis was negative from her knee. She was rheumatoid factor positive initially, but was ACPA negative. She was shared epitope positive, and she got this label as rheumatoid, and she was treated with various DMARDs for like 7-8 years. And I inherited her in my clinic, and she said she got 200 attacks per year, which is a lot. Doesn't seem credible, does it? And her CRP was usually normal, but it was elevated during attacks. Now, I'm not loud enough. I can speak louder, yeah. So as you can see from these images, she has lots of shininess and joint erythema. So this is a palindromic or an innate immune type arthropathy. This is a paper from Spain, which obviously is in the Mediterranean basin, like yourselves. And basically what it showed was that in seronegative rheumatoid arthritis, there's a very high carriage of the MEFV gene, or heterozygosity. So this is linked to FMF, as you know better than me, and occasionally in heterozygote forms. So some of this seronegative rheumatoid is really an innate immune-driven pathology. So whilst most rheumatoid is closer to autoimmunity, there is some rheumatoid that sits closer to the innate end of the spectrum. So this is an article we've published recently trying to address this. And what we're doing is we're putting rheumatoid along the innate to the adaptive contribution. And whilst most of the disease is the adaptive immune down here and the interaction with macrophages, which can be targeted with methotrexate and anti-cytokines and B and T cell therapy, there are some subgroups where there's these severe attacks which are innate immune driven, which may respond to colchicine or indeed interleukin-1 blockers. So the question is, I know my talk's about biologics, but it's difficult to escape the fact we now have JAK inhibition. And the question is whether these modern JAK inhibitors, which are the 21st equivalent of corticosteroids insofar as they target multiple pathways simultaneously, and they target, amongst other things, IL-6, and IL-6 obviously is another cytokine that's strongly linked to innate immunity. So the question is whether these agents will make a difference in treating the entire spectrum of rheumatoid, because they lack the specificity of the biologics we've been using for this past few years. And obviously some of the big cytokines involved in autoinflammation or innate immune-driven diseases, including an FMF, are not dependent on JAK signaling. So this is a suggestion that maybe JAKs don't cover everything. So in this article we published recently, we highlighted how there's this extreme heterogeneity within what we call rheumatoid. And down towards the autoimmune end, you've got ACPA-positive rheumatoid. This is the classic form. There's rarely you can see monogenic disease in the rheumatoid variant. That's due to abnormalities in T or B cells. Monogenic inflammatory arthritis like FMF and Blou's syndrome can manifest as rheumatoid. And then crystal disease can manifest as rheumatoid. It's driven by inflammasome and interleukin-1 activation. And psoriatic arthritis can also have a polyarthritis that's MHC class 1 linked. So it's slightly different. So this is an article we published last year, and it's basically 5 cases of patients who had ACPA positive or shared epitope positive disease, and they had a disease that looked like rheumatoid, except they also simultaneously had these severe acute attacks, which are very debilitating, sometimes with raised CRP and joint erythema. And these 5 cases did not respond to conventional DMARDs. And to summarize these cases, all 4 of the 5 had SNPs or mutations or rare variants in genes known to be linked to autoinflammation or innate immunity, including NLRP3, MEF-V, and NOD2. These patients had severe attacks, resistant even to anti-TNF, and some of them responded very well to colchicine added into the therapy, and some also showed an excellent response to anti-IL-1 strategies. So this is just an example of one of these cases, ACPA positive, but getting these severe attacks with erythema. We actually miss these. The patients tell us in the clinic, but the attacks are short-lasting. So I tell my patients who give these descriptions, please take a photograph during an attack and show it to us. So this is to highlight this heterogeneity within what we call rheumatoid arthritis. And whilst biologics and rituximab and abatacept and anti-TNFs work well, and although JAK inhibitors seem to work well in most patients, there is, I believe, an overlooked significant or substantial innate immune contribution. And some of this is actually superimposed on top of the classical autoimmune mechanism of disease. So just another thing to summarize, when you think of ACPA-positive RA, the target's likely to be the synovial membrane. When disease is capsular-based, this may occur in crystal deposition in patients with seronegative RA who actually have polyarticular gout. So different anatomical sites of involvement in the joint, including enthesis for seronegative disease, may allow us to help define these subgroups, but this is still in its early days. So just one brief thing to say about cytokines and rheumatology. If you take the adaptive and innate continuum, which we proposed in 2006, you see that the autoinflammatory and crystal diseases are very much IL-1 driven, where autoimmune diseases like lupus and autoimmune myositis, they are linked to type 1 interferon expression. So there is this remarkable cytokine polarization between innate and adaptive immunity in medicine. So here's a disease that had was originally called a variant of rheumatoid, but Bywaters recognized that it was the adult equivalent of pediatric Still's disease, and this can be a rheumatoid-like arthritis with high fevers, periodicity, and other extra-articular manifestations. And this is a nice paper from Italy showing that that the Still's disease actually responds very well to IL-1 blocking strategies. So again, this points towards the cytokine heterogeneity that exists in diseases we view as rheumatic. Now, I'll say one thing about IL-6 as a target. IL-6 is a unique cytokine in that it's clearly linked to autoinflammatory diseases and hyperinflammation driven by innate immunity. So it seems to be a target in Still's disease-like phenotypes. But IL-6 is also a vital cytokine for B-cell maturation, plasmablast and plasma cell development and differentiation. So IL-6 is actually a cytokine that simultaneously targets innate and adaptive immunity. And in rheumatoid arthritis, there's generally better responses to IL-6 blocking therapy in patients that are ACPA positive, showing the very important role of IL-6 as a cytokine that can play in both autoimmunity and autoinflammation. So I just want to say a few more things about these difficult cases that come to my clinic. I run a joint autoinflammatory rheumatology clinic with my colleague here, Sanisha Savage, and we get patients with rheumatoid-like phenotypes, but also rashes, serositis, erysipelas-type lesions, and they get high fevers. And this is a paper we published in Journal of Clinical Investigation Insight. And these patients are negative for all the autoinflammatory genes. They're negative for autoantibody screening. And these patients consume a lot of resources. They may be in hospital for 3 months and being investigated, for example, for endocarditis and other diseases. And this is just to show that lots of tests get done and they get lots of different manifestations, including rash and arthritis, and some are called seronegative rheumatoid. And this is one of these cases when we diagnosed it, very high CRP, and we put the patient on an interleukin-1 receptor antagonist, and the patient did very well. And then she got caught on holidays in Spain in 2010 during the Icelandic ash cloud, and she ran out of drug. She came back home to England and she nearly died. She went into liver failure and marrow failure and became profoundly hyperferritinemic and was septicemic. But after 3 weeks in ICU, she got back, and now she's well controlled on an interleukin-1 blocking strategy. So I just want to emphasize that if you're working as a rheumatologist and you're using cytokine antagonism strategies, you will see these patients where it has rheumatoid or stills or poorly defined rheumatoid features where there may be a strategy. So I know Arabs love horses and Irish people love horses. So in rheumatoid arthritis, the anti-TNF works. But in diseases like autoinflammatory components, interleukin-1 actually can be a great target. But obviously, most countries around the world, interleukin-1 therapies are not licensed for rheumatoid. And the other problem is that the only licensed agent we have, anakinra, does not potently block interleukin-1 beta, so it's relatively ineffective. So the second half of my talk, I'm going to speak around the seronegative diseases. And just like rheumatoid arthritis, the clinical trials not only treat the patients, but they dissect pathogenesis rather beautifully. And the only cytokine that's really shared between psoriatic arthritis, psoriasis, and AS and rheumatoid is TNF. But all other mechanisms, the cytokine mechanisms, IL-17, IL-12, 23, IL-23 blockers, do not work in rheumatoid, but they work in these diseases. So they're telling us something fundamental. So this is just to remind you that all of the available biologics, and I want to emphasize the TNFs here, they're very effective in psoriatic arthritis and the spondylospectrum. And they're also very effective in ankylosing spondylitis. So accordingly, at the dawn of the biologic era, people said, well, it's all the same, you know, these diseases are not that different. TNF works in rheumatoid and it works in these diseases. But now we know that patently not to be the case. So this is a really nice study in Annals of Rheumatic Disease by Smolin, Joseph Smolin, who's now editor of that journal. And it's a study in rheumatoid arthritis, and there's a placebo arm, and there is 2 ustekinumab arms, and then there's guselkumab, which is a pure IL-23 blocker. And as you can see, this is the placebo response. The pure IL-23 blockers are worse than placebo, which is difficult to do in rheumatoid, to be worse than placebo. The IL-12-23s had a marginal effect, but at higher response rates, there's no difference. So again, this is telling us something really fundamental. And the good thing is that this is reflected in GWAS studies and genetics where there's multiple hits linking the IL-23 and 17 pathway to seronegative arthritis, but not to rheumatoid. So this is to put this in context. So ustekinumab blocks the P40 subunit, which is shared between IL-12 and IL-23, whereas guselkumab, risankizumab, and tildrakizumab, and there are more on the way, block the P19 subunit of IL-23. So as you can see, this is specific for IL-23. Now, it turns out that in this last few years, a new cytokine, a theoretical cytokine thus far, called IL-39, also shares P19, and it's important for driving lupus in mice. And there are studies looking at ustekinumab in lupus in humans where it was positive in phase 2 results. So these pathways may have a role in lupus, but if I was an investor, I would not start spending my money in lupus because the outcome measures are not that good, and I think they make the drugs look bad. So compared to rheumatoid arthritis and the anti-TNFs, one thing that's coming from the registry data of IL-23 pathway blockers, and the same can probably be extrapolated to IL-17, although we wait long-term follow-up, is these drugs are remarkably safe. There's very little evidence, this is ustekinumab, very little evidence of serious infections compared to the anti-TNF. And remember, this drug's blocking IL-12, so with pure 23 blockers, bearing in mind that they may also block IL-39, which is not well defined, and IL-17 blockers, it looks good for safety. So I'm just going to say a few things now about IL-17 inhibition. So this work started out in rheumatoid arthritis, where secukinumab was no better than placebo. Ixekizumab was slightly better than placebo, but it hasn't been developed. So these drugs don't really work for rheumatoid, but they seem to work in the seronegative disease. So this is one of the studies in psoriatic arthritis by Novartis in the Future program. And the two licensed doses are the 300 and the 150 milligrams. So this is a standard phase 3. And this is showing compared to placebo, the ACR20s are in the region of 50%. So in the region of the anti-TNFs. The other thing about these agents is patients have a fairly rapid onset of action, but these subjects get loading doses at 0, 1, 2, 3, 4, and then monthly injections. So that may contribute to this. And then the patients maintain good response in psoriatic arthritis. This is patients that have had prior biologics. So split up into biologic naive, the ACR20 is much higher at 6 months, whereas those that have experienced previous anti-TNFs, the ACR responses are lower. This always happens in rheumatoid arthritis, and it now seems to always happen in psoriatic as well. That is, if you fail one biologic, you tend not to respond well to subsequent biologics at the population level. I just point out that one of the problems of failed studies in psoriatic arthritis is that many of the patients that have failed may have normal CRPs, and they're that age group that get osteoarthritis. So failed biologics may not mean disease activity. It may mean multifaceted pain, including osteoarthritis, fibromyalgia, obesity, mechanical problems. And this is something that we could talk about. And there's lots of ultrasound studies going on at the moment showing that people we think have active disease, at least a quarter of them don't have much to see in ultrasound. The issue of methotrexate, again, the presence or absence of methotrexate in all phase 3 studies with all drugs in psoriatic arthritis does not appear to make a difference. So these are people on baseline methotrexate and no baseline methotrexate. So no major difference in the ACR20s at week 24. These studies of the IL-23 and 17 agents have very good resolution of enthesitis and dactylitis, which are secondary outcome measures. So here we have for dactylitis, 56% resolution, where the resolution of enthesitis is slightly lower. This is because dactylitis is easy to measure, you see it or you don't, whereas enthesitis is more subjective, in my opinion. And the other thing is that we know that the anti-IL-17s and the IL-23s are much better in skin disease compared to the anti-TNFs, where both agents in the clinical trials seem to be comparable. With the anti-IL-17s, there's no radiographic progression in the majority of cases, but as you can see, there's some people, very few, that have up to 20 sharp units progression. So there's some rare resistant disease, and this is due to the immunological heterogeneity. I'll say more about that. I mentioned this earlier in ankylosing spondylitis. There is also one IL-17 licensed, secukinumab, and ixekizumab has just published very good phase 3 data. And this is with the 150 milligram dose of secukinumab. And again, rapid onset of action and good ASAS-20 outcomes which are maintained. So we need obviously registry data now. There's very little in the way of neutralizing antibodies to secukinumab in clinical trials. In any of the disease indications. And as I mentioned earlier, these drugs seem to be remarkably safe in the real world. And some respiratory infections, no tuberculosis, no demyelination, and no autoimmunity. So in certain cases, that would make you naturally inclined potentially to use them as your first biologic. So the question is, which is better, an anti-IL-17 or an anti-TNF strategy in psoriatic arthritis? Answer, nobody really knows, but I would say this is the best data we have. So this is Lilly's study of ixekizumab. So there's 2 doses here, monthly or fortnightly, and an adalimumab reference arm. So this wasn't a randomized control trial, it's an active comparator they put in. I don't know exactly how they do the calculations, but as you can see, compared to placebo, anti-TNF and the anti-IL-17 agent looked very similar for arthritis, although the anti-IL-17s are much better in skin disease. There are some studies in the literature now claiming that the anti-IL-12/23s or anti-IL-17s are better for patients with isolated peripheral enthesitis. And there are people saying that you should use an IL-17 of patients with psoriatic arthritis have lots of enthesitis, and you should use a TNF if they have lots of synovitis. So this is the sort of thing you will hear and read about, but it's not really backed up by the limited data we have. So what's the future hold? So I mentioned the ustekinumab blocks IL-12 and 23, and now there's 3 pure IL-23 blockers. And the first one, 2 now have done phase 2 studies in psoriatic arthritis. And this is ACR20s of approaching 60% in the phase 2 study with guselkumab, and also very good PASI 100s of 40%. So these agents are probably going to be developed. Now, one of the big setbacks that the anti-IL-23 agents have had, and this is razunkizumab, in a recent phase 2 study published in the Annals of Rheumatic Disease. Here's placebo in gray. These agents were no better than placebo. So we've got this very odd observation where we have a drug that works for synovitis and enthesitis in psoriatic arthritis, this class of drug, but they don't work for enthesitis and osteitis in the spine. So this is very interesting observation, and it has now spawned lots of laboratory research into this area. Now, we know that ustekinumab does not work in angst-spond, but in studies looking at back pain in psoriatic subjects with axial symptoms, ustekinumab showed significant improvements, including in the back pain domain of the BASD score. So you can see these differences here. So this is data showing that IL-12/23s appear to work for peripheral enthesitis in clinical trials. Compared to placebo, there's improvement in peripheral enthesitis. Yet we now know that there's no benefit whatsoever in 3 phase 3 studies in axial disease, and everything's been stopped. This is razunkizumab, so another IL-23 blocker, and very good in skin disease, as you see here. And now there's data in psoriatic arthritis, so this is likely going forward. Again, we can't avoid talking about JAKs because they're the new kids on the block. Now, the one thing I'll say about JAK inhibition, this is tofacitinib. So the PASI 75s are much lower than you see with an IL-17 or IL-23 blocker. So that means that in rheumatology, JAK inhibition's here to stay, but in psoriasis, it's not. It's not in the same league as the 17 or 23 blockers. Now, several companies are developing JAK inhibition for TYK2, which might block IL-23/17 pathway signaling. This is looking at tofacitinib versus adalimumab in psoriatic arthritis. So this is the JAK1, JAK3. Here's the adalimumab arm. And as you can see, the JAK at both doses compare very well or slightly better than the anti-TNF. So this is in psoriatic arthritis, which is interesting. So I'm nearly there. So to summarize, when you think of diseases, it's not always easy to say if it's autoimmune or innate immune, but we do know that B cell, T cells target autoimmunity. Cytokine strategies, including interleukin-1 right up here, TNF, IL-17, IL-23, and next on the radar will be IL-36. These can target innate immune diseases. And then there are diseases that sit in the middle where there's innate immunity and T-cell involvement, and you can come at them in a number of different ways. So this is an example of this heterogeneity in seronegative spondyloarthropathy, just like you see in rheumatoid. So this man was 48, and he had inflammatory bowel symptoms and also symptoms in his spine. His CRP was elevated, his MRI is positive, he was B27 positive. He developed psoriasis and a severe oligoarthritis, and he basically failed 4 anti-TNFs. His gut had settled spontaneously, and then he failed IL-12/23. So there's not a lot you can do, so you just get whatever drug you can. So because his CRP was very high, we realized that he was seronegative rheumatoid all along. So we were able to give him tocilizumab. And this is a case series we've published, and there's other case series in the literature of resistant spondyloarthropathy that's completely failed to respond to TNFs or IL-17s now that respond to an IL-6 strategy. Now, obviously, IL-6 uses JAK signaling, so this may be a place to use JAKs in these resistant cases. So just want to show you, you might say IL-6 is not relevant. Here's an animal model where the mouse gets a rheumatoid-like arthritis, and it's due to dysregulation on this negative regulator of NF-kappa B called A20. And when this is knocked out in macrophages, the animals get an arthritis that looks a bit like rheumatoid. But this is a myeloid cell dependent disease. It's TNF independent, just like our patients, and it's IL-6 and IL-1 dependent. And the earliest lesion in this mouse model occurs right in the tip of the Kager's fat pad and retrocalcaneal bursa in the Achilles tendon. So you see it's a type of seronegative disease. So there is animal precedent for this IL-6 dependent disease that gives enthocele-related pathology and synovitis. So this is work done with Dirk Elwood's group. Finally, we have these patients, and I'm sure you do as well, where the patient responds very well to ustekinumab historically for their skin, but their joints are no better. Then you switch them to an anti-TNF, and their joints get better, but their skin is terrible. We now have this happening also with the IL-17 blockers. So this is a series of 6 cases we just published in Rheumatology last year, showing that sometimes we have to use combination biologics to control the totality of the psoriatic disease. The problem with this, as you might imagine, is it's leading to more chest infections and hospitalizations with pneumonia. So it is a long-term concern. So this may be an area where JAK inhibition might have a role, but that remains to be seen. So to conclude, I've given you a bit about the biologic therapy of rheumatoid arthritis and spondyloarthritis. I've tried to come at it not with data sets from phase 3 studies, but about what you see in the real world and how disease is difficult to treat, and how there's this clear differences emerging between cytokine pathways and biologics between autoimmunity and the more innate immune pathologies and spondyloarthropathy. And then within spondyloarthropathy, as I was saying earlier, you've got this differential pathology as well, which makes life very difficult. So I've ended up saying the same thing at the end of 2 talks. So thank you very much. I'm happy to take questions.
Thank you. Thank you, Professor McGonagle, for this excellent presentation. You are so late, and I ask if you have only one question.
I have one. Thank you very much. Actually, my question about secukinumab. As it is effective in treatment of uveitis in patients with spondyloarthritis, do you think may take a place in treatment of uveitis for another cause rather than spondyloarthritis?
This is ustekinumab.
Yes.
Ustekinumab for uveitis. So it's a very good question.
Especially for resistant cases.
Yeah, so very good question. Ustekinumab has a license for inflammatory bowel disease, right? And that's a good sign. The trouble with the dose of ustekinumab we use in rheumatology, it's very low. If you have somebody with sight-threatening uveitis, then these small loading doses may not work. So if you can give them a Crohn's loading dose, which for the rheumatologists, just to point out, it's up to 520 milligrams, which is the equivalent of 3 years rheumatology supply. I think if you can give a high loading dose, it's a very good chance that it might work, but there's not enough data, yeah? And there's going to be no data in Angst-Bond where it doesn't work. So it's a very interesting question. There's not enough data.
Actually, we have a lot of patients who is resistant even to 3 or more than from anti-TNF alpha inhibitors, even interferons. So that it will be interesting to try such.
Oh, this is in lupus. You sticking them up in lupus or?
No, I didn't try it, but I think it may be interesting to try such a drug in such resistant cases.
And I fully agree. I mean, as we heard earlier on this morning, TNF-resistant uveitis, and particularly the macular edema that the uveitis triggers, which can cause blindness at the fovea centralis, yes. That responds to IL-6 anecdotally. So that is certainly an option. The problem we have, we rheumatologists have time. You know, if our patient's joint doesn't get better in 2 weeks, that's still okay. But in a uveitis clinic, 2 weeks of untreated uveitis and they're going to go blind. So it's a difficult area, but certainly more studies are needed. And I think it comes down to the extreme heterogeneity. We need to be able to figure out in advance which of these uveitis cases are TNF dependent, which are IL-6 or which are IL-12, 23. It's a very good question.
The last question, Dr. Adwan.
Thank you.
Marwan.
Can you comment on the use of CD19, anti-CD19 in rheumatology?
Anti-CD19.
Yeah, do you have any experience with the anti-CD19?
Yeah. So our dermatologists are using. I do a joint dermatology clinic, and they've been using it as part of clinical trials. So very effective for skin, like same as anti-IL-17As. No fungal infections. Also works for there's phase 2 studies showing efficacy in inflammatory bowel disease. Obviously doesn't work in AS and seems to have some efficacy in PSA.
Not in RA?
Oh, no, it's completely failed in RA, completely failed.
Failed.
Yeah.
Oh, okay, Thank you.
You finished? Yes, the last question for Dr. Adwan.
Thank you. Thank you for this interesting talk.
Thanks.
Especially the talk about FMF and the interaction between rheumatoid and autoinflammatory diseases. In fact, in the past, some people considered FMF to be an autosomal dominant disease. But we know that's now due to the fact that some mutations are not sequenced. We only sequence exons 2 and 10. Yeah. And the other reason is could have been a modifier gene
Yes.
which may be the gene in the HLA haplotype and rheumatoid arthritis or something. But that doesn't explain the fact that in this part of the world where we have a carrier rate of around 1 in 5, but the rheumatoid arthritis we see here is a fraction of the rheumatoid I used to see in the UK.
Yes, so I deliberately included the data on the auto-inflammatory rheumatoid because I know about the high carriage rate of up to 20% of MEFV in this part of the world. And I know that I just wanted to emphasize that, you know, rheumatoid arthritis is a different disease in Japan and in Europe and a different disease in the Middle Eastern area. And I'd be interested to talk to you more what you think about that. Is there more seronegative rheumatoid here in Jordan compared to Europe, for example? Less ACPA positivity? Yeah, I see, yeah. Okay, so most are seropositive, yeah.
Okay. Thank you
Thank
to all
you.
of you for your attendance. Thank you, Dr. Denise. Thank you for all of us.